here today. Thank you for joining us at this panel discussion and the virtual launch of the POCSO fact sheet, the fact sheet on the POCSO Act and adolescents' access to safe abortions in India. As we all know, the MTP Act was recently amended to broaden the conditions as well as the gestational periods within which to access safe abortions in India. And of course, in September 2022, we had a landmark judgment from the Supreme Court of India as well, which has further strengthened sexual and reproductive rights and health in India. But of course, even despite all of these, adolescents' access to SRHR remains a complex issue. And it is stigmatized, and they remain vulnerable to various issues within the legal framework as well as outside it, as we will hear more during today's panel discussion. And of course, we have Dr. Alka Barua, who will also speak a little bit more about the fact sheet and what we try to do here. This fact sheet, of course, has been developed collaboratively by the Law and Marginalization Clinic at the Jindal Global Law School, the Common Health, the YP Foundation, the Hidden Pockets, and the Center for Reproductive Rights. So without further ado, on behalf of all the collaborators, again, a warm welcome and, to what promises to be next 1.5 hours of really exciting conversation with our moderator here, Krishanu, and an esteemed set of panelists. So over to you, Dr. Alka Barua, and welcome once again, everyone.
Yeah. Thank you, Bratati. I hope I'm audible. Good afternoon, everybody. My name is Alka Barua, and I lead abortion team for Common Health, which is a coalition of 300 plus individuals and organizations that work for reproductive health and rights. I would like to give a little bit of background about development of this fact sheet on the Protection of Children from Sexual Offences Act, or the POCSO Act, which was brought out, as Bratati said, by Center for Justice, Law and Society, Jindal Global Law School, Center for Reproductive Rights, Common Health, the YP Foundation, and Hidden Pockets Collective. The POCSO Act, as most of you know, was enacted in 2012 in response to the growing instances of child sexual abuse and violence. And the intent of the act was to protect children from offenses of sexual assault, sexual harassment, and pornography. It adopts a very stringent carceral framework and criminalizes all sexual activity involving a person below the age of 18 years. With imposition of very strict punishment for such acts. In fact, Section 19 of the Act makes it mandatory for a person who has apprehension or knowledge of an offense committed under this Act to report to the Special Juvenile Police Unit or the local police, and such a person can include a service provider. This provision is known to deter adolescents, especially in cases of consensual relationships, from seeking sexual and reproductive care, particularly seeking abortion in cases of unintended pregnancies. It also violates the right to privacy, bodily autonomy, and dignity. It compounds the challenge that adolescents already face in accessing safe and legal abortion, given the requirement of guardian consent under the MTP Act. A number of adolescents in consensual sexual relationship have in the recent past sought judicial intervention in such situations. Just 2 months back in September 2022, the issue of evolving adolescent capacity to engage in consensual sexual activity and the conflicting provisions of POCSO and MTP Acts were taken up by the Supreme Court. The court ruled that it is necessary to harmoniously read both POCSO and the MTP Act, and the registered medical practitioners, those who are approved for service provision under the MTP Act, can terminate pregnancy in such cases without disclosing the identity and other personal details of the adolescents when complying with their various legal obligations. This particular fact sheet has been developed to explain the legal framework which is currently governing abortion services in the country and the adolescent sexuality in India, as well as the chilling effect the legal framework can have on adolescent access to safe and legal abortion services. It also informs users about the recent Supreme Court judgments and legal obligations of service providers. This is in short about why the need for the fact sheet was felt and why it was developed. With this, we would now like to move on to the panel discussion. I would like to invite Prishanu to moderate the discussion. A little bit about Prishanu. Prishanu is pursuing MA in Sociology from Ambedkar University, Delhi, and works in the field of sexual and reproductive health rights. Prishanu has been instrumental in establishing Naan Biryani Delhi, which is a non-binary collective, and has also been a student activist and fellow at the YP Foundation. Over to you, Prishanu.
Thank you so much, Dr. Alka. That's such a sweet little bio note that you shared. So obviously continuing from Dr. Alka's conversation that she's opened up for all of us to talk about today, and in the respect of the launch also today, these are some very pressing concerns, and especially in the juncture of time that we're currently in, very relevant to talk about also. So I'm also very, very glad to have with us today the three esteemed panelists that we do here right now with us. I also am aware of all of their work, and I'm really excited to the conversations that are going to follow from here. So also just a note to the interpreters also, if I'm going too fast, please let me know. Yeah, so from here on, I think firstly I'd like to introduce Dr. Zoya Rizvi. Dr. Zoya Ali Rizvi has been the Deputy Commissioner at Health National Mission, Ministry of Health and Family Welfare, Government of India. Dr. Rizvi has over 2.5 decades of experience as a state program officer in Himachal Pradesh from 2011 to 2014. Dr. Rizvi has worked on health programs for children and adolescents. Dr. Rizvi has also worked for a medical officer in the Ministry of Health and Family Welfare. The New Delhi Municipal Corporation and the Development of Health of the Government of Himachal Pradesh. She serviced her MBBS from King George Medical College, Lucknow University, a certificate in adolescent health services from the WHO, and an MSc from the London School of Hygiene and Tropical Medicine. So I really welcome Dr. Rizvi on the panel. Next, we have with us Ragini Borodole. Ragini is also a colleague at STEPS. We have a network of, again, young folks who work for adolescent healthcare, in which I worked with Ragini before, and I've had the pleasure of knowing Ragini. Ragini works in research advocacy on sexual and reproductive health and rights. In 2018, Ragini launched My Vagina, My Rights, a platform that curates medically verified and evidence-based information on sexual health and menstrual hygiene. She is also currently a fellow at USAID's Momentum Country and Global Leadership Program. Previously, she worked with the Mariwala Health Initiative and the YP Foundation. Welcome, Ragini, to the panel. With that, we move to my very personal favorite, Biraja, who's also been a SAFE fellow, as I was also a SAFE fellow once. So Biraja is also somebody I know from other works that we've done together in the larger sort of trans queer activism in India. Biraja is a researcher and trainer in gender and sexuality at Nirantar Trust, a network member of the Huck Over Stigma Network, and a co-creator of the Feminist Leadership Lab by Gender at Work India and the UN Women. They were formerly a SAFE fellow with the YP Foundation and are passionate about queer rights, sexual and reproductive rights, digital media, and community media with intersections of gender. They obtained their BSc from Odisha University of Agriculture and Technology and their Masters in Arts of Gender Studies from Rajiv Gandhi National Institute of Youth Development. With that out of the way, the formal introduction, I think we can just get into the panel for now. And I would like to sort of introduce the larger thematic that we're going to work around, right? Like, you know, in this panel, we are going to talk about adolescents' access to safe abortion, which is like the larger thematic, and definitely we'll go with at different specificities with the different panelists on, you know, their areas and the kind of things they have to say. My 2 cents before we do begin is that in my work too, I look at fee social categories and then their access to abortion. Because obviously inequalities are graded. And in that sense, then access becomes very important question to ask, because then access also becomes graded for different communities in that sense and groups. One group that has not been a part of this conversation in that kind of a level or that kind of with that kind of prominence has been the adolescents group. So one such category is the adolescent and younger population and their access to healthcare. So, as a country, we do pride ourselves with the fact that we are the largest youth population, something like that, some population wise. We do say that very often, except the question then that I arrive at is that what do you do about it? Very good. The population data you have, brilliant that you have young population or we have young population, but what do you do with that information? Is this going to data becoming instrumental in formulating policies which tackle the kind of issues that youth are facing? It does not. Or does it? It's a really open-ended question then, so knowing this sort of a social identity that India forms at a global level of being a youth country, to what end is also my question then. Then we need to look at things from that perspective. Yeah. And when it comes to the question of adolescence, one thing that also keeps on happening very often is infantilization. So I'm sure everybody's going to talk about it, and that's why I shall stop here. So just to prompt all of our panelists, I will start with understanding the kind of stigma around adolescent sexuality, and just a prompt, honestly, and this could be everybody's introductory sort of comment on this. In no order, if there's a preference, anybody would like to go first, please do. Otherwise, I'll pick.
That is scary to be picked for speaking, Krishanu. So I think I will go first. Yeah, since you've been hammering the point of the demographic dividend which India is so proud of, and on so many platforms we do refer to the 25 crore adolescent population of India. So I actually agree with what you say, and I would go ahead and say that adolescent population, like you have mentioned, is one of the rapidly changing age group in which they are physically growing, mentally, socially, sexually, which has been mentioned, growing. But still, and we do have programs, but then there are critical gaps still perceived in all our implementation programs. And these programs, I would be honest enough to say that a lot of gaps are because of the lack of information, which you mentioned, whether it is access to sexual health services or sexuality or even basic menstrual hygiene practice, anything. So first is lack of information, and this emanates from lack of information given to them at homes or in schools. Second, I would say, is also the provider bias. Again, this provider bias is, I would say, from the perspective of the healthcare provider. So this huge bias against young people accessing service. Now, whether this service is related to sexual health, whether it is related to even mental health. So there's a huge bias. Why do these young people need this? Is it right? Is it kind of, right in inverted commas? Third, I would say that a lot of our adolescents and young people do not have that agency of accessing service also. They don't know that there's a service available, and they don't know, and even if they know their service, they don't know where to go. So that is lack of information from there also. And I would say, even if they know where it is, they don't have access to it. They may not be able to travel due to lack of funds, or the ability to travel that is there. So there's lack of agency in accessing and information. So that is what our the program which government is running is kind of threefold, I would say. There is facility-driven interventions, there is school-based interventions, and there is community-based. So what we are trying is, since this age group spends a lot of time in schools, we'll try and catch them young so that we inform them about their own health, nutrition, gender, equality, mental health, emotional well-being, relationships. All those things are an essential part of the school health and wellness program, which is going to be implemented across all the districts, covering about 26 crore young children who go to schools. So that is the target which we are looking at, which the government is implementing in coordination with the Ministry of Education. So that is a school-based intervention. Now, what happens is that a lot of, we mentioned about access to termination of pregnancies, MTPs, that has to happen in the health institution, and that is where a lot of the access, we know about 20 lakh adolescent girls get pregnant every year, and more than half of them end up in abortion, and about 10%, say about 2 lakh of them need safe post-abortion care, which they don't get. So there is a huge gap in need and what they actually get, and that is where I would say provider training, sensitization, and repeated sensitization is something which is required, that it is a right to give service, to have access to service. That is something first every healthcare provider should say, that, okay, you want service, this is how, where the safe service can be given. And of underage, that is where reporting, I mean, which is the whole, I think, paper is referring to, is the need of reporting of underage pregnancies, in which the chance, because of the whole POCSO Act being a protective act, that is where the whole struggle of the healthcare provider, services, and reporting happens. I think I will pause here and I'll listen to the others.
Thank you so much, Dr. Rizvi. So I think next, would Ragini like to go? Sure.
Yeah. So first of all, thank you for inviting me. I'm very grateful to be here today. You know what, it's very interesting that I'm closing off this month by participating in a conversation on adolescent sexuality, adolescent health, and how laws like POCSO can sometimes act as a hindrance. You know, in the beginning of the month, I participated in a national level conference on adolescent health, where doctors and pediatricians and health practitioners from all across India, and I think Dr. Rizvi was also there, you know, participated in the conference. And I was talking on meaningful engagement of young people in policy making and policy decisions, and why, because of non-inclusion of young voices in these policies, there's a huge discrepancy between what people who don't have any experience or any lived experience regarding the complex, you know, the complexities of sexualities, you know, in today's time, which is why sometimes the language itself is very prescriptive, very alarmist, and it's not very, you know, affirming, which is why a lot of adolescents for whom these policies are made, for whom these programs are made, don't exactly reach these very beneficiaries that we want to target. And what happened was that I met with a few objections from a few doctors who very, you know, right away protested that, you know what, I agree what you're talking about agency, I agree what you're talking about, you know, having informed decisions. But then unless and until you're 25, your prefrontal cortex is still growing. So what you think of is a decision, an informed decision, might be a rash decision. And how, as practitioners, are we supposed to support you in doing that? And in that very moment, when they said that, it was the power dynamic was created, where this person was speaking from 35 years of experience as a medical practitioner, and I at 20 something. You know, even though I have my own experience as a young person, and I have been, you know, interacting with young people ever since I was 19, because I have been working in this field ever since my late teens. And suddenly there was a denial of my own agency. There was a denial of the fact that even though young people in adolescence go through this tremendous cognitive, behavioral, sexual, biological changes, and yet they do not have the capacity to take their own decisions. And I sort of now get why these laws are made in the first place, you know, because, yeah, I mean, this denial of adolescent sexuality is in a sort of way doesn't take into account that young people, regardless of what religion says, what culture says, what law is there, is going to engage in intimacy, is going to engage in sexual intercourse, and what the consequences will be dealt on later on. You know, when I was engaged in the SAFE project, I think which Biraja was also a part of, one thing that came up was that young people, and especially marginalized people in Assam itself, when they don't feel safe for reaching out to doctors, they go to their local midwives, they get their massages. Half of these people are anemic, and half of these people then, you know, have to deal with fatal conditions because of blood loss. I, as a young person, have to take up calls from other young people, 14, 15 years old, who, you know, call me up and just ask, I had sex with my partner and I missed my period. If I take 2 pills, will I be like 100% sure that I will not get pregnant? And if the pregnancy has occurred, it will be aborted. Now, in that moment, I'm not thinking of ethics. I'm not thinking of legalities. I'm thinking that this person should be safe right now. Which is why, as a road forward, as a road ahead, I think, and also I would like to mention that when I spoke about that thing, there was a consensus in the room that, okay, there has to be conversation, there has to be multi-sectoral collaboration between health practitioners and lawmakers, that sometimes the laws that are intended to make, secure the rights of people and make, keep them safe, can also act as a hindrance in their accessibility. And I think which is why I find it interesting that today we are closing off this month by doing the exact same thing, right? We are raising the initiative and initiating the dialogue.
Yes.
And I think going forward, there has to be a mechanism where you can probe into the possibility of abuse, possibility of violence, the possibility of the pregnancy occurring from an act of violence. But there has to be cognizance of consent. There has to be cognizance of adolescent sexuality. And I'll definitely speak about it as and when more questions come up, but this is what I want to share right now.
Thank you so much, Ragini. I mean, the experience aspect of what Ragini is talking about is very, very crucial, because mostly in the rooms that we're having conversations about marginalities, or even then populations like adolescent populations, we very often do not have them in the room. So I think that's very important. Thank you so much, Ragini. And I think we'll now move to Biraja for their introductory note. Thanks.
Am I audible? I would like to check because my internet is really, really patchy.
You are audible.
Yeah.
In an event that you're not, I think we'll text on the chat.
Yeah. So it's really glad. I'm really glad that I was like, all of you thought of me to be on this panel, and it's so good to see so much familiar faces. I've worked with Ragini and Krishano before, so it's so nice. So in my introductory note, I will not go into say much. I'll raise few questions. Because we are talking at the intersection of reproductive healthcare and child rights, which are very important. And I'll speak from the work and my experience and the community that I work with and belong to. So first of all, when we talk about reproductive rights, we all know that a certain kind of bodies are prioritized over other in terms of how the policy language are framed and how even medical infrastructures are designed. I mean, who can go and get an appointment with a gynecologist in a government hospital depends on what you wear, how you dress, how you look and stand and get that ticket to enter into a government hospital. Because I'll also speak mostly from government, I'll ground my arguments in public healthcare system, because I feel that I come from a state where the condition of public healthcare is so bad, and beyond the capital city, Bhubaneswar, the private healthcare system is also bad. You really cannot access it. So how do you access public healthcare is also so much about how you look and how your body is. So during the SAFE fellowship, when I was engaged with the community in and around me, and we were mapping the friendliness, after which also I have followed working with them, I realized that when you are a trans masculine person, how you look plays a lot of role. I mean, you raise a lot of eyebrows even while going to the hospital and then accessing abortion, and what goes inside the room, that comes later. It becomes really, really difficult. And similarly, if you're a trans masculine person and you're pregnant, and then further it complicates that it raises questions about your trans masculinity, because how can you be a trans masculine person and still be in a relationship with a cis man, right? That one question comes up. Similarly, another question that comes up is that if you think that you are a man, and it is asked by supposedly progressive doctors that if you felt like you were a man, then why did it take so much for you to decide that you're a man? Why didn't you decide it earlier? you spoil a family, like, because we are so much our everything around pregnancy, everything around birth is so much invested in family that these two questions come up very frequently. So when we say accessibility, accessibility is not always about good advice, good services, immediate intervention. It goes beyond that. It's about how do you reach to that infrastructure. Even for certain communities, even that is a question in a country or in a state like Odisha. The second question is about child rights and child sexuality. Even in the heteronormative framework, child sexuality is a very, very contested uh, area. Feminist debates have been gone into that. What is it, like age of consent for that matter, like, which is a debate right now going on. So it's a very, very complicated area, and often we resort to easy paths of saying that consent is yes, no. But at the same time, there are very, like what Ragini was saying, there is adolescent sexuality, and people have desires. People tend to resort to derive pleasure. They understand their body in different ways. In that context, in global and Indian debates, do you even consider a trans child? That's another question. I mean, when we're talking about a 16-year-old deciding to take hormone, or a 16-year-old trans masculine person, trying to design their body in a certain way, and designing a body is very important part of trans existence, right? Like how we design our body, because sort of you choose to be who you are. So and you also want a certain kind of body. Per se, I might not want breast, but I would like to have my vagina. I do not want my uterus. These are the complicated questions that certain people deal, and these awareness comes because there is a very huge community network, even on the ground, even what we call the so-called rural. There also these networks are there where trans masculine people really reach out to the elders of the community and come to these terms. So do we even consider a trans child? Because in India, in the current policy frameworks, no policy includes trans children. Like you cannot go to a child home, you cannot access when it comes to Juvenile Justice Act. Nowhere we are addressing this question. In America, there is a huge debate around whether a person has consent to even change their body when they are below 18. That's a debate that's going on. So do we even give them agency to sort of be who are they? So, of course, there are complications, but when you bring out these non-binary experiences into play, I feel policy cannot hold or cannot contain the trans experience. That is why I find it a futile exercise to sort of locate the question of accessibility, the question of rights in a policy framework, especially from a trans perspective. Uh, I would say the answer lies beyond. The work needs to go somewhere because, of course, a policy is needed. And of course, the larger population it caters to. But for trans people, or for that matter, a lot of like even people from marginalized caste, for them, accessibility issues are much more different, which in Indian context, policy can't contain. So, yeah, that would be my introductory remark. I will provoke all of you to think around these questions.
Thank you so much for that opening remark from your end, Viraj. I think one thing that I gather from what you've said, and not really gather, but something that I believe in and I would like to also reiterate, is that we really tend to jump for some kind of a universal truth around everything. We're like, ये है, इसको universalize कर देते हैं. Everything has to somehow be everywhere. You know that movie, I don't know, every time, everything, all at once? Can't. So there's so much specificity to so many experiences because these are lived realities we're talking about, right? We're not laboratory numbers that you're crunching, that you can just look at them and say, ye hai trend, wo hai trend. You can't really do that because we lived experiences of people. And in that sense, genuinely, can you really do that without understanding the complexity? So definitely when we're having an intervention towards policy or law, this kind of an understanding needs to go that in that case, then the choice and decision making should rest with the person whose body it is. So yeah, so with that remark, I think we'll move to the next part, which is, in your own ways, I would like all of you to reflect on barriers to access for adolescent population specifically. So obviously we've been talking about larger ideas and also some like experiential aspects of it, but at the same time, in our context that we are all embedded in, not again universally, in more specific terms, what do you think becomes barriers to access them? And, maybe other things around it also. Don't have to really stick to this, but, just to prompt. And again, if we can follow the same pattern, it'll be nice.
Okay, so I need to go first. Okay, so since we are following the same pattern, so you put me in a spot now because I already mentioned, I think the barriers I mentioned essentially in my introduction, and that is why we are trying to implement a program which is improving access to basic services by young growing children and adolescents, irrespective of which gender, which sexuality they belong to. And that is why we have a lot of our, okay, so I'll just talk a bit about the other access which you mentioned. Is that school is fine. School is one thing which is kind of institutionalized, and you have a captive audience, and what do they do? If the teacher tells them, they'll actually listen. But what about the kids who don't go to school? So that is where we have a program which is called the Peer Educator Program, in which the peers are selected from within the community. So they can be either in school. Some states have taken in school, but majority of states have taken out of school peer educators, because that is where we realize these young people who don't have access to education are the ones who are really in need of maybe more information. Because I think our agenda per se as a policymaker, I think, forgive me for whatever I think feelings you all having policymakers, we do tend to be dense, I mean, so much judgmentalism is there because you kind of build your own based on your own experiences. But again, going to the fact that that the adolescents and the young people who don't have access to education are anyway more vulnerable for a large gamut of service access which they don't have. So once we train these peer educators on sexual reproductive health is one major component, on gender-based violence and other prevention of violence, on mental health, on prevention of non-communicable diseases, also on how to have a healthy lifestyle. So all these things they're kind of trained, and what is assumed and what is expected of these peer educators is that they will transact within the community and inform. So these peer educators are young people, and which I'm even listening from you all is that whatever information is discussed with peers is something which can be debated upon, can be discussed, rather than maybe talking to a service provider. You can't go to a doctor or a counselor and argue, because I mean, like which Birja mentioned and Ragini both, doctors do tend to be judgmental, and like, I am so well educated, how can you argue with me? That thing often comes out with, and the higher specialist you become, the worse it becomes often, which we have also interacted. And in fact, to be honest here, we also interact with a lot of our healthcare providers, because a lot of the inputs end up being very technical, So technical inputs many times don't get translated into policies, into interventions. So it is a hard time for us as policymakers to bring out things which are easily understood by the adolescent and young people. So I'm so happy to be here, because I would say any planning for young people should be centered with them, because that input we'll have to take from you all. Okay, this is what really matters for us. This is something which is important, but I need more help in this, or maybe I need more support in this, or maybe we need more funds in that. So that is the kind of thing which we are trying to grow within the government, that whenever you're implementing any component, do take feedback. And then there's nothing like one concept which is like, nothing is written on stone, because as you all are fully aware, gender is anyway something which is fluid, So if that understanding is there within our own healthcare providers, a lot of basic services will really not suffer. Now, coming to the contraception, the access to MTP, the safe abortion services, that is something which again, once the capacities of the healthcare providers is built regarding essentiality of service provision, irrespective of which gender the person belongs to, irrespective of the way they look like, what they're wearing, that is something which again has to be reiterated and hammered in. All of us know that the more you are trained, not to say that the training quality is not good, but you do need repeated trainings, because once trained, it doesn't really help, because you do need to reiterate with more with interventions, with support, which has effect. And now more and more digitalization, and more, I think, good quality IC material, which is also being created. A lot of this is being shared with the healthcare providers. But yes, I would say that is where we lack. A lot of our healthcare providers come with their own baggage. So that baggage, to kind of dismantle that baggage and to put in something in its place is really quite tough. And we are struggling with it. You're talking about MTP, we are struggling with a lot of basic access to services. When a young girl even comes to ask for sanitary napkins, that is an issue for our healthcare providers, So for them to able to explain what is a sanitary napkin, how to use, how to dispose, is an issue. So we have to begin by basics. So then we always say that you build inroads by just talking about, say, nutrition, and then from there you build. So nutrition is a kind of non-contentious topic. So you kind of begin with nutrition, whether with a young person who accesses, and then from there you talk to mental health. And of course, but that freedom should be with our young people who are accessing, that if you want to talk about gender, about access to SRH, that I think that comfort has to come, which I think will take effect. I'm being honest here. We are trying to build, to upgrade the knowledge of our healthcare providers. During lockdown also, we trained about 2,200 counselors online, and repeated counseling training is being done, because counselors are essential part of our healthcare services for adolescent and young people. That is being done. Upgraded training of medical officers and peer educator, which I mentioned, is being done. But yes, I think we have to accept as a policymaker that a lot of it needs to be done, and that's where we need to help, so that inputs keep coming, and then we can strengthen the program.
Thank you so much, Dr. Rizvi. I think I do agree that, there's this shared table that we need to come at more often, to have these dialogues, to be able to understand each other's concern in that sense, right? So yeah, I think I will also not take much more time, and we can now go to Ragini.
Yeah, thank you, Krishanu. Well, you asked me to talk about barriers and not universalize the conversation. So I'll talk strictly from my own context. What I have noticed here is that if here young people do not even know that abortion is accessible. So the one thing they do is that they go to the pharmacy, take an over-the-counter pill, and almost always at a very high price range, that is more than the market range. Just a few weeks ago, like a 16-year-old had to go to the clinic, and the urine test cost her 1,000 rupees. It shouldn't cost her 1,000 rupees. And this is a person who in the moment of desperateness will also steal the money to get it done, right? And as the barriers get more and more complex, the moment, the web of marginalizations, the intersections, the more we explore those intersections, the barriers also get heightened. For example, if you come to the tea communities here in Assam, tea garden communities, the doctors themselves sometimes just very rudely, ask them to go away and say, "Tum log ka hi kyun hota hai? Tum log ka hi kyun hi tum log ko abortion chahiye?" Just very blatantly. And which is also why most of these people, they go to local midwives, choose unsafe methods of abortion, regardless of whether the safe methods of abortion are there in their communities. The fact that safe methods of abortion are available and that abortion is legal doesn't always reach out to the people, and especially young people here, right? And I think, since we are talking about adolescent sexuality and the cognizance of adolescent sexuality, we also need to broaden the meaning of it. We need to move beyond penovaginal sex, what sexual intimacy even is. And, a lot of it, we have to consider the way our own sexual lives have evolved. Someone who has grown up in the last decade will not exactly realize that how, sending nudes or sending intimate pictures is such a common and prevalent practice in, relationships nowadays. So for law to recognize that this is happening, someone in the same age group has to be there, making those decisions, being in the same table. We need to recognize these nuances. And especially, since law is also intervening in the way our access is determined and how our access is defined, I think a lot of us, our generation, and people from different marginalizations have to be included in these policy making decisions, so that, we get to cater to these exact loopholes that remain loopholes because it just remains in the conversation process and never materializes in reality. Right? And I think as for now, these are the barriers, and even doctors do not know that how, even suppose who is a well-meaning doctor and wants to provide an abortion service, might feel that they will come under the radar and they refuse the abortion process. And I think I went through the fact sheet, the POCSO fact sheet, and it does a very great job at delineating the case laws and the precedents, and how sometimes the court has already said that you need to prioritize the health aspect of it, and then you can go and just report it without mentioning the information and mentioning the confidential aspects of it. So even doctors have no idea about these inconsistencies, and how sometimes the law can also, basically there needs to be more conversation with medical practitioners, with health practitioners, and between policymakers, and just let them know how to navigate this in a more youth-friendly and more affirmative manner, I feel.
Yeah, thank you so much, Ragini. Yeah, so what I'm gathering from all of our conversation is this sense of structural problem of access in terms of public healthcare, or then looking at healthcare providers and their distance from the people who are there to access these services, right? So I think these are some thematics I'm able to identify. So yeah, let's move on to Viraja then. Thank you.
Yeah. So, like what Krishanu said, that one biggest barrier that I would, of course, it's a universal barrier, but I think it's a very, very crucial barrier to access abortion or any kind of healthcare is lack of public healthcare. In Bhubaneswar, where I worked, there is primary healthcare centers, but primary healthcare centers do not have a I don't know in terms of policy what are the guidelines, but they do not have a consultancy that can uh, offer information or advice around pregnancy or abortion. It isn't there, but the number of primary healthcare in each ward has increased, and it is there. But once you go there, they direct you to another places. So lack of more privatization around, there is a dangerous privatization around accessing abortion, and you have to pay a lot of money, and it's a discrepancy and you can't address it. So I feel that's a huge barrier, because not everybody has that kind of financial or economical independence to sort of afford it. So affordability is another barrier, and especially for working class trans people, often who have migrated from their houses, like they have ran away from their houses and in a city and struggling. For them, it's a struggle for housing, it's a struggle for food, it's a struggle for everything. So then that becomes a barrier. Secondly, information. I think we're still in the era of shame, where we are not doing enough public awareness campaigns. There was a time when there was a government, public awareness campaigns were core to policy. Like there would a policy come and there would be public awareness campaigns. But now in today's time, Doordarshan has become irrelevant. There is not enough posters that are available on roads talking about where are the abortion facilities. Like, why don't we, there are enough data in every state. Like there are these ministries, and there are mission health mission, where there are lists are there, but those lists are never put out publicly. There are no instead, again, we put advertisements of commodities. So I see that is a larger problem that is related to privatization or where our economy is heading. Though it's a very specific problem to the city, there are other states where it is happening, but in Orissa it's not happening. And I would like to relate it to a larger structure, like where privatization of healthcare is happening and it's real and the consequences are happening. Because if there are enough information in a digital age, if there is a public awareness campaign, the websites are open, or the document, it should be open, but they are not. Or if that's not there are posters outside when you get out of your house. If those would be available, people can easily dial a call. Instead, there are posters of private clinics who very mysteriously offer abortion, which is very dangerous. Third thing is, again, which I mentioned in my initial remark, that what's your body, how you look, how you talk, who you are. Those are the problems. But and I feel in terms of our policy, I think our policy framing or how we look at policy again is very much divorced from the language. It is stuck in a certain kind of language. I feel even though we do trainings for doctors, which I have tried, I have engaged with them, we go and tell them that, okay, this is how you deliver your service. That is the language we are stuck with. Like you have to deliver a proper service. But I feel when we talk about adolescent and adolescent sexuality, we have to do away with that language and we have to bring pleasure in, we have to bring danger in, we have to say that there is pleasure, but also when you explore pleasure, there is danger. We have to bring in the language of body. We have to talk about desire. We have to talk about how bodies look like. We really have to go into what does a body look like. I think these are the way in which we should do training, design our training modules for the authorities. If we stick to that very bureaucratic language, very sanitized language of, oh, A, B, C, D, E makes a good abortion, and this is the information that needs to be imparted, then even though they understand it, they won't judge you on the face value, and they would be that nice person who says that, hello, what's your pronoun? They will ask you all of that, they offer, but they would never understand your reality. I feel it. I feel the training modalities need to change, and the language of pleasure and danger needs to come in. And I realize that often when we talk, also another problem with the woke society today is we are so much focusing on pleasure, that our body, our rights, my body, my rights. We are focusing so much about the pleasure aspect of our body, especially in urban woke, a certain kind of language people who have. I also feel that we have to sort of look critically into that in the name of being progressive, are we also addressing, because there is pleasure when you explore without information in current society, there is also danger, as in like you do not know, like per se, until and unless you have an unsafe sex, maybe till that point you've never thought of doing an HIV test, right? Nobody is talking about it. So I feel these kind of vocabulary needs to come into our training languages, how we are training. Maybe it cannot make into the policy framing language for certain kind of barriers or certain kind of structures that are placed in, but how do we make through it is through bringing these languages into the implementation part. And it's tiring to explain people because there is so much shame attached in saying in these words like my body, pleasure, seeking, I seek this, I need this. Even the language of need is not there. Like if I say that I need sexual pleasure, people will shame me, right? So, and I think these are some languages which universally applies across identities. Even though our problems are specific, in certain ways we have to also look at unifying experiences, right? So that we can talk and we call in people instead of like calling out that, oh, this is not enough, that is not enough. I think,
Yeah, thank you so much, Raja. I think it was really a comprehensive picture of barriers on multiple levels. And another note that I would like to make here is that when I say specificities also, it's not to mean that, we only are going to talk in our own context. The specificities of the larger structural problem, specificity of the neoliberalism mechanism, how it functions. So how neoliberalism functions is not in one uniform way everywhere. It is a specific operational structure and mechanism and tools in different places. For example, on a project that I'm working with Alka ma'am here also, it's with sex workers, right? So even for them, while doing this preliminary research I came across was that one person had to pay 60,000 rupees to get abortion by pills at a private hospital. And that happened. Why? Because the private hospital said that it is illegal what you're doing. We're going to help you get to do this. For that, you have to pay this much money. Right. And that now connects to the way awareness and all that Viraj was also talking about. Again, my area, like I also work on the awareness aspect of abortion access. So state withdrawal from things like awareness will create more space for more private entities to come in, because again, profitability is there. So in that vacuum is the work that lies for us and for everybody for that matter. So yeah, from here I will ask like Disha, Natasha or Anmol, anybody can give me like a check on the time, because I have one more prompt for the panelists and then we can move to questions. Would that be okay?
Yeah, absolutely. We have about another 10 minutes. So I think that's fine.
Oh, great. So of course. Thank you. So I think next, and something that I was thinking about having a conversation about for a very long time, I've been literally poking people that let's talk about it and have not had the opportunity. Thanks to everybody for inviting me. I'm going to make everybody talk about it. Is that November 5, 2022, in a recent Karnataka High Court judgment, the bench consisting of Justice Suraj Govidranch and G. Basavaraja directed the Law Commission of India to reconsider the age of consent prescribed under POCSO Act. So this is a very recent occurrence that has happened. And in this light, then, this case is interesting to me, and I'm sure to all of us, I mean, to some extent, because we work in this area, is also because the case that the bench was hearing was about this young person who's 17 who eloped with a man, and that is when they got impregnated, and that's when the family filed this case or brought it to the attention of authorities. And because POCSO has this suo moto kind of thing in it, so you know, the moment you get to know, you need to report. So the reporting happened, the case is filed, the case has been going on, the couple got married, they have 2 children. So that's the case right now, and that is why the Karnataka High Court has given this judgment. But at the same time, what I feel, I want just, you know, I'm just giving facts of the case and other ideas around, and you'll have to comment on it, is what your task is. Another note that I'm making here is that, you know, I'm also very always suspicious of any kind of legality entering my life and my body. Because of being a trans person, I understand how my lived reality are constantly being negotiated by my visibility, invisibility, constantly in all kinds of spaces. So in that sense, any kind of legality does not always mean it's a good thing. So in that sense also, it's very interesting to also note that the bench also said something that not only Law Commission, but also Karnataka government and the Principal Secretary of the State Education to constitute a committee and establish a suitable education material in this regard, so that students are aware of the consequences of their actions. So the bench also then said in the same breath that, you know, POCSO needs to reconsider age of consent. The bench also said in the same breath that people need to be made aware of the legality around POCSO, young people, adolescent population, so that they're aware of the consequences. And they have directed the state, what is it called, education department, to make some kind of a module around it for awareness, right? Now, why does this sound familiar? Why does this sound familiar? That if you have sex, you are going to face consequences. So this sounds so much like, you know, abstinence. Like, abstain, be good citizens, abide by law, be safe, and, you know, don't have sex, as if that's going to work. So yeah, I'll leave it here and I'll go to Dr. Rizvi right now, and let's see what she has to say.
That's a dangerous line. I cannot talk against. Okay, so I can't really talk against some matter which is subjudice, right? That is something which I cannot comment on, being a government servant myself. But I think all of us have passed through the adolescents. We have adolescents in our own home, young people. I have got 2 kids. I got nieces, nephews. And you do have to realize that this is an age in which, like you say, everybody need not be having sex, but a lot of people are having sex. So that is fine, you know, but as long as you keep yourself safe, I mean, that should be all right, you know, and safe, right? Like Biraja mentioned about HIV, if you look at the NFHS 5 data, it's about, I think 21% of women know how to protect themselves and about 30% of men. So we are not even informing our young people, you know, so we are failing on a lot of levels. So it is not just education, but healthcare providers. We have to empower our young people to make the right choices, whether it is, like you mentioned, Krishanu, whether it is abstinence, fine, it's your choice. But in case you want to indulge in sex, keep yourself safe, you know, so that you don't end up looking for services where there are huge barriers, whether it is MTP, whether it is testing for HIV, testing for STIs, then getting treatment for that. So yes, I would say our motto should be, whatever you do, keep yourself safe. And in case you need to access services, you should know where it is. So that, I think, is something which has to be maybe come down. That information has to channel down to young people, that yes, it is fine. I mean, everybody will need service sometime or the other, but it should not have those barriers, should not be there in case you need. And that's where I think as healthcare providers, we come in. We have to, I think, do away with a lot of train ourselves how to talk to, make a young child, a young, say a trans or a non-binary, whatever, comfortable in talking. And once you are comfortable in talking, then only you tell us what service you need. So once the initial comfort is there, then service access, service provision will automatically come in due course. But yes, there is time, and I'm being honest here. A lot of hard work has to go in from our point of view as policymakers, as implementers of program, that we have to, and as Viraja mentioned also, we have to sit on a table and say, okay, this is how it is done. This is how you feel comfortable. So why don't you come across and we discuss, and maybe the kind of case studies we put in, the kind of quizzes we have in our trainings, the kind of questions we have, let us get our own healthcare providers thinking. You think, and then it should not be just top-down approach that, okay, this is how you do it. Let them think. And then I think we do have it in us in providing services. Why not? We just have to give them the platform and the wherewithals of doing it. And of course, your support will always be very helpful.
Yes, I think we are sort of running out of time. So we need to sort of quickly move to our comments on this. Yes, Ragini.
No, you know what? I resonate with you when you said that you're very skeptical of legality defining how you should live your life. Because until recently, law had restricted queerness. I mean, it did not make sure in, defining that it did not have any effect on whether queer people lived or not. Queer people existed despite the criminal status of queerness, right? They might have been made invisible. They might have been exposed to violence or even death, but that did not have any effect on their existence. So whenever legality also tries to, control and dictate at what age you should start having sex, when you should start feeling pleasure, my body, the innate body, the soul which knows pleasure, which knows the sexual, feelings, will not really care about what the law is saying. And this is exactly when things become clandestine. Things become, things start happening behind closed doors, behind closed curtains. And exactly in this situation, this is like the, hotbed of stigma and taboo, right? So I feel that since you're talking, also the second point that you mentioned about dangers and knowing the risks, this is also what informed consent is. And this is also why policies and just laws will not do anything. There also has to be comprehensive sexuality education in all levels. And this is exactly what informed consent is. If if I'm seeking an abortion right now, the doctor has to ideally tell me what are the risks involved. And then I'll consent, okay, I need this procedure right now. So I think knowing about the dangers is also part of the curriculum. It's just that right now the vocabulary exclusively focus on the dangers of it. Don't have sex because you will catch HIV. Don't have sex because you will catch STDs and STIs, right? Just because it is exclusively very alarmist and focuses on what not to do. It's exactly why people become very separate from, what they're trying to do. So rather than focusing on what correctly, how to keep yourself safe, because you are entitled to pleasure, you're entitled to safety, you're entitled to healthcare. And this is exactly why, you need to, this is how you can keep yourself safe also while enjoying your own autonomy. So I feel in this juncture, I think this is where the solution lies and we need to explore.
Yeah. Thank you so much for answering that question. Yeah, Viraja, your comment on what I've just said.
I'll just say that, I mean, I of course, it's a matter of judiciary and everything. And I would like to say, propose one thing, that, of course, laws, policies, and precedences are important. And they're precisely important to document a certain kind of legal history. Beyond that, we should really liberate ourselves from placing our expectations on the law or policy that it will offer us everything that we need. Like Rishanu said, everything in one policy. We should really liberate ourselves. The work needs to happen somewhere. And another thing is that when we say that, when we have to talk about dangers, not necessarily we have to have a language of policing. I mean, that we tell them people that, okay, these are the dangers, and now you have to stop doing whatever causes this danger. I mean, that's precisely a language of policing. And to be honest, in our everyday life, we do not make this differentiation. Starting from families, schools, workplaces, everywhere, we do not differentiate that, okay, there might be dangers, and because dangers, and to prevent that, we just go and stop. We ask people not to do what causes it. I think that is very divorced from what a very, very basic human reality, that we seek pleasure. And it can be sexual, it can be otherwise. I mean, we live in a country where even basically desiring someone and without any sexual without any sexual desire, just desiring someone is also criminal, right? So I feel so we have to look, when we're speaking of danger, is it also invested in the concept of pleasure? Are we prioritizing? If we do that, the language will automatically change. I have seen it happening. I have seen it happening when community members talk to each other. It's not something that's very far away, very impossible. When people say that, nobody in the queer community says that don't seek sex, right? When you are devoid of structural way of finding companionship, nobody is going to come and tell you that you don't find a companionship, don't seek pleasure. Everybody tells, but everybody also tells you that keep these things in mind, right? Or if you go through something, reach out. So these are other ways of talking about danger, and we should talk it. And expecting law to speak in this language would be it would be a stretched expectation. I don't think law can talk in that way. Maybe while we are implementing law, we should think of making spaces for these words, like I said.
Thank you so much to all the panelists for bearing through all my poking and probing throughout the session. Now I think we'll move for questioning. Before that, I think Dr. Zoya is leaving. So I would just like to thank Dr. Zoya to be part of this panel on behalf of all the organizers, myself, and the other panelists. If you have any words, last, few words you want to say, Dr. Zoya, to all of us, please, I invite you to do that.
Few words is I would say, be strong, hang in there. I mean, your hard work, it doesn't ever get noticed, it doesn't ever get not noticed. You do your good, and it's bound to have good effect later on. So I have faith in yourself and some faith in us also.
To both of those things, it's hard, but we'll try. Thank you. So now I think I'll invite questions from the audiences and anybody else who want to ask the panelists anything. There's already 2 questions here in the, okay, one is a very technical one, which I think the team can handle. The other one is, doesn't reporting without revealing identity of the victim defeat purpose of mandatory reporting under POCSO? How would this play out in particularity? It is by, I don't know, would this person want to be named? I'm not sure. So yeah, so somebody's asking the question, doesn't reporting without revealing identity of the victim defeat the purpose of mandatory reporting under POCSO? Okay, whoever wants to go first, Viraja, Ragini. And also Dr. Alka is here, so possibly Dr. Alka wants to say something that will be also interesting.
Well, theoretically, it would, absolutely, it would, because law says something, but when it is implemented at the ground level, it is a very different reality altogether. Because what happens is when reporting, first of all, the threat of reporting itself will be a major deterrent to service provision. While reviewing the RKSK program, we have come across cases where when the service provider has talked about reporting, the service provider has faced violence, as well as people refusing to seek care and going away from the center. So that also happens. The second thing is that the service provider themselves are not aware of their legal obligations. When we are talking about adolescents not being aware, even service providers are not aware of their ethical obligations, their legal obligations. So unless they come to know about what the Supreme Court decision is, what are their obligations, and which is where this fact sheet we are hoping will be of some help, which will tell them what to do. Until that happens, well, reporting will happen the way it has happened till now, that the name would go, all the details would go. So that's where it is.
Yeah, I think I also agree with Dr. Alka on that end. Is there anything else that the other panelists would like to add to this one particular question?
Just to say again, another thing is that certain laws are made keeping certain questions in mind, and then there are nuances that comes up, and I mean, there are different nuances that has come up in different kind of work that I do. The question of early childhood marriage and the question of elopement, and it clearly conflicts. And then whose right do you protect actually? These are the questions that comes up, like whether you report anonymized, which purpose the defeat of course, POCSO, when perpetrators can be family members. So, you know, there are no answer, no straightforward answer to certain kind of gray areas that are in laws and the realities that unfolds in very complicated way, where like for someone the elopement can is a survival, right? But then and the family members do use the legalities to sort of bring back the concerned party to the back home, and it and then it is a struggle when you're working with the community mobilizers who are really handling the cases day-to-day basis. They come up with all these, and uh, you I don't know. I mean, I don't know what to do there legally. I mean, it is a case by case thing that goes. Every district court has one sort of challenge. Every high court has one sort of petition regarding POCSO. So it becomes really complicated when you bring two different kind of like child rights and abortion rights together, child rights or sexual rights together. It becomes complicated, and I again think that law cannot withhold. There should be always petition, there should be always legal ways of challenging them and bringing new precedences. But I mean, does it really translate it into ground? We should all think.
Yeah, thank you. Yeah, thank you so much for that comment, Viraja. So with this, I'll give exactly 30 more seconds for anybody to ask any other question, and then we'll move. Anything else you would like to say also, closing remarks in the meantime, if somebody's formulating their thoughts? Both the panelists, any closing remarks?
I mean, I think I would just like to add to what Viraja said as a closing point. I think, is my internet working, by the way? Because you said okay. Since I also feel that we are in the presence of lawyers, or at least law students, I think we all can agree that law is not exactly black and white, and all of your bread and butter lies in exploring the gray area, right? And also, just as an anecdotal experience, here when pregnant people under age of 18 go to ASHA workers, when they are registering the birth the age, even if this person is under 18, the age is just written as 18, which later on becomes the data that we see on a national level. So the data we have is botched. Secondly, a lot of these are already happening. We are already walking the gray area. It is not black and white. So I think I'll again reiterate the first point that I made when I was giving my, the first, when I was speaking about exploring there should be the doctors, when you are, suppose I'm going to a medical practitioner to seek an abortion, the practitioner has to probe into the possibility of violence. Yes. And while also taking cognizance of my consent, despite my legal status as a minor or a major. So I think this is where the complexities come in. It is a case-to-case basis, but it cannot be black and white. Human beings do not operate in zeros and ones, right? It cannot be true and false. So I think this is where we need the gray area we need to explore, and this is where law can also accommodate these nuances going forward.
Yes, thank you so much for that beautiful remark about just like a principal thing, which is the absolute grayness of our lives. Yeah, with that, I think I do not see any questions, and I did give you all a time frame. So with that, I think I would like to invite you all to join me in launching the fact sheet on POCSO that has been formulated and made by all the organizers today. We'll watch a short video. So yeah, let's do it. Yeah, over to you, Atira.
Thank you, Krishanu. Am I audible? Thank you to our wonderful panelists, moderator, and all the attendees for holding space for this fascinating and engaging conversation. On behalf of Hidden Pockets Collective and our collaborators, the Law and Marginalization Clinic, Center for Justice and Law Society at Jindal Global Law School, Center for Reproductive Rights, Common Health, and the YP Foundation, we would like to extend our gratitude to Dr. Rizvi, Ragini, Biraja, and Krishanu for joining us for today's panel discussion and bringing forth important conversations for us to take forward. Your perspectives and inputs are invaluable to the discourse around abortion services and adolescent sexuality in India. We also want to thank everyone whose efforts and contributions have given us the opportunity to come together to curate and launch the fact sheet on adolescents' access to abortion. We would like to acknowledge the phenomenal work done by our Indian Sign Language interpreters, Shivojji and Stutiji, and the design team and IT department at Jindal Global Law School for all their support. We are also grateful to our collaborators, Bradadi and Kritika at CRR, Vinita and Vinida at the YP Foundation, and Professor Deepika Jain, Disha, Natasha, Rishav, Ramani, Anmol, Akhil, Sanyukta, and Surbi at the Law and Marginalization Clinic for bringing this project to fruition. We hope that this collaborative endeavor leads to an increase in legal awareness and dissemination of information about the legal framework on abortion services and adolescent sexuality in India, as well as the chilling effects of this legal framework on adolescents' access to safe and legal abortion services. We also want to thank the Vice Chancellor of Jindal Global Law School, Dr. C. Rajkumar, for the unwavering support for this work. Our final and most important word of thanks is for our audience who have taken the time to join us today and engaged with us on Zoom and other social media platforms. We are so grateful to you for taking the time to join us and in the discussion, and hope that you continue to engage with us in other social media platforms. On a closing note, we would like to inform you that the fact sheet will be available on our website. Also, the video for this panel discussion will be available on YouTube and other social media platforms. Thank you for joining us today. We hope you have a wonderful evening ahead.
Thank you so much, everyone.
Thank you.
Thank you so much.
Bye. Have a good day.
Bye,
Rest of the day, all of
Krishna.
you.
Thank you. Bye, everyone.
Bye,
Have a good
Brother.
evening, all of you. Bye.
Bye.
Bye, everyone.
Thank you. Thank you, Dr. Barua.